So today I'm going to be talking about management of traumatic peroneal nerve dysfunction. I have no disclosures. So a little bit of outline on today's talk. First, we'll talk about the presentation of these injuries. Then we'll talk about the anatomy. We'll also talk about the causes, then the diagnosis, and the treatment options. So starting with presentation, peroneal nerve injury is the most frequently encountered neuropathy of the lower extremity. It's a common cause of foot drop. Strength tests will reveal weakness in dorsiflexion and eversion of the foot. Patients with chronic injuries may develop chronic equinovarus deformities as well. Injury can occur along the sciatic nerve, but most commonly occurs at the level of the common peroneal nerve around the knee. Additionally, incomplete injuries where the superficial peroneal nerve is spared, patients may get overpull of the peroneal tendons leading to a pes planus deformity. So next, a little bit on the anatomy of the common peroneal nerve. So the common peroneal nerve is derived from the L4 through S2 nerve roots. The peroneal division forms the posterior lateral division of the sciatic nerve in the thigh, which predisposes it to stretch or injury during surgeries around the hip or trauma around the hip. At the knee, there are three branches, including the articular branch, the deep peroneal nerve branch, and the superficial peroneal nerve branch. In approximately 80% of patients, the common peroneal nerve splits into the superficial and deep divisions at or distal to the fibular neck. However, in up to 10% of patients, the bifurcation of the common peroneal nerve occurs proximal to the lateral joint line. The superficial peroneal nerve innervates the lateral compartments, and the deep innervates the anterior compartment musculature of the leg. Terminal branches of the peroneal nerve provide sensory innervation of the dorsal foot in the first web space. At the knee, the blood supply of the common peroneal nerve is tenuous, and this combined with its superficial location leads to more injuries, and when it's injured has less chance of recovery. So now we'll talk a little bit about causes of peroneal nerve injuries. Causes include multi-ligament knee injuries, often associated with knee dislocations, proximal fibula fractures, penetrating injuries like gunshot wounds or stabbing injuries, acetabular fractures, as well as pelvic ring injuries involving the L5 nerve root. The rate of common peroneal nerve palsy associated with multi-ligament knee injury has been reported as low as 16% and as high as 40%. Most commonly, these are associated with injuries that involve the posterior lateral corner of the knee. Additionally, proximal fibula fractures can be associated with these injuries due to its close proximity to the common peroneal nerve. The peroneal nerve, peroneal division of the sciatic nerve can also be injured following acetabular fractures. These are predominantly associated with transverse acetabular fractures with posterior wall components, as well as isolated posterior wall fractures. Motor nerve injury following acetabular fractures has been reported to have a 4% incidence of nerve injury, and half of these involve the common peroneal nerve. One study showed that about 24% of patients who sustain these types of injuries don't recover any function at final follow-up. And pelvic ring injuries, either the injury or fixation of the posterior pelvic ring can be associated with an L5 nerve root that leads to a peroneal nerve injury type picture. So a little bit about diagnosis. Initial evaluation should include plain radiographs if they weren't initially obtained, as oftentimes you can miss trauma to the knee or the proximal fibula that was missed due to a minor trauma and patient not reporting much pain around that area. MRIs can also be helpful in detecting associated ligament injuries, and it can also be used to evaluate the nerve if certain sequences are obtained. Ultrasound may also be used to evaluate specific location and length of common peroneal nerve injury. However, it's very user dependent. Additionally, nerve conduction studies and electromyography can be used to assess nerve function and injury. These are usually not to be performed within the first 2 weeks of injury, and usually are performed at 6 weeks, 3 months, and the 6-month mark thereafter to monitor recovery. These can be used to assess severity and ultimately give a prognosis to outcome of patients with these injuries. Pertinent EMG findings corresponding to acute nerve injury include positive sharp waves and fibrillation potentials. And chronic denervation is marked by fasciculation and complex repetitive discharges on EMG. Next, we'll talk a little bit about treatment. So in general, conservative management is the initial treatment option for foot drop that's caused by common peroneal nerve palsy, either at the knee or caused by injury more proximally at the sciatic nerve. If the patient has any motor function on exam or any activity on EMG, then serial examination should be performed, as there's compelling evidence that ultimately these patients will improve. If the exams are improving and EMG finds normal insertional activity post-injury, then watchful waiting should be prescribed. Oftentimes, it can take up to a year to regain function. Therefore, patients should be counseled regularly, and encouragement is needed to stay the course with non-operative treatment. During the waiting period, patients should be fitted for a spring-loaded AFO. Also, some have advocated for the use of muscle stimulator to help minimize atrophy of the tibialis anterior muscle. Additionally, frequent stretching should be prescribed to prevent any equinus contractures at the ankle. So a little bit about prognosis on these injuries. There's a mixed bag of data on these, just given the high variety of injuries and associated injuries with these. But this was a recent systematic review that looked at peroneal nerve palsy following traumatic knee dislocations. They reviewed 13 articles that included 214 patients with common peroneal nerve palsy. They found a 26% incidence of common peroneal nerve palsy associated with these knee dislocations. They found that nearly 40% of patients with complete injuries ultimately recovered strength greater than 3 out of 5 on final strength testing. Additionally, they found that 87% of those patients who had a partial palsy at initial time of injuries recovered full strength. This can be used to encourage patients, especially those with partial injuries, that ultimately, if they wait and utilize your AFO and keep stretched out, then recovery can be seen at final follow-up. So if no function appears to be returning at around 6 months, a discussion should be had with the patient about treatment goals. Treatment in AFO indefinitely is feasible, but several studies have shown users of AFOs, especially young patients, are generally unsatisfied and non-compliant with the device because of discomfort, hygiene, and mobility issues. So treatment recommendations in the literature are primarily directed in patients with dysfunction due to multi-ligament knee injuries, and this will be the primary focus going forward in this talk. But in general, management goals for common peroneal nerve palsy causing a foot drop are similar regardless of cause or level, and in general include promoting neurologic recovery, maximizing functional recovery, minimizing risk and functional loss with nerve or musculotendinous reconstructive procedures. Prognosis and management are influenced by numerous factors, including patient age, timing of injury, mechanism of injury, longitudinal extent of the common peroneal nerve that is damaged, and distance of injury location from the nerve to the distal targets. So treatment options in general include neurolysis, nerve repair, nerve graft, tendon transfer, and ultimately nerve transfer as well. So good outcomes can be seen with neurolysis, especially if some function is present preoperatively, as previously stated. A recent study by Toma and colleagues demonstrated that 19 of 20 patients achieved at least 1 grade of improvement in strength testing with neurolysis at time of initial surgery. Another study looking at neurolysis alone that was performed outside of any other multi-ligament surgeries found that 8 of 11 patients ultimately achieved greater than 4 out of 5 strength testing with neurolysis alone. Average time to surgery was about 5 months. With this in mind, most recommend that the nerve is explored and neurolysis at the time of surgery if it is found to be in continuity, if they're undergoing a multi-ligament knee reconstruction or any other type of procedure. If there are no initial surgeries performed, then neurolysis should be performed at 3 months if there are no clinical or electrical signs of improvement and the nerve is confirmed to be intact with advanced imaging like ultrasound or MRI. So if the nerve is not intact, the nerve repair can be tried. Direct epineural repair is a procedure of choice when the common peroneal nerve is not in continuity and the zone of injury is small, and you're able to get an end-to-end repair without undue tension at the repair site. However, knee dislocations especially are very traumatic and often have a large zone of injury, making this very difficult. Given this, outcomes of nerve repair have been average at best. Additionally, following knee dislocations, the common peroneal nerve fibers are often severely stretched, making you have the need to section and take more nerve than you initially thought. ultimately not allowing you to have a tensionless nerve repair. A study out of Louisiana State in 2004 retrospectively reviewed 19 patients who underwent direct repair. They found that 16 patients achieved greater than 3 out of 5 strength at final follow-up, and repair ultimately got patients out of AFOs in this setting. So if repair is unfeasible, then nerve grafting can be employed. Oftentimes this is utilized because of large zone of injury, like previously stated. Usually the graft is about needs to be greater than 4 centimeters to bypass the zone of injury. Autogenous graft is the gold standard, and the sural nerve is usually utilized. Mixed outcomes on nerve grafting have been reported, but the main theme in the literature is that there's a poor prognosis for recovery in patients who require greater than 6 centimeters of nerve grafting and any injuries that are associated with vascular injury. So this is a recent meta-analysis looking at nerve repair and as well as nerve grafting. There's 28 studies that involve 1,577 patients. Ultimately, 17% of patients achieve 4 out of 5 strength with nerve repair, and 16% achieve 4 out of 5 strength with nerve grafting. As previously stated, they found significantly better outcomes in patients who had their nerve repair performed within 6 months of injury and grafting that was shorter than 6 centimeters. So as previously seen, nerve repair and transfer have unpredictable outcomes. For this reason, tendon transfers have been indicated when there is no return of nerve function after a nerve procedure or an ample amount of time has been observed to allow for nerve recovery. This usually happens at around the 1-year mark. Tendon transfers utilize the posterior tibial tendon. They've been described for many years. The posterior tibial tendon is generally transferred through an interosseous membrane, which has been shown to be biomechanically superior to subcutaneous transfer to various locations on the dorsal midfoot based on surgeon preference. It's usually into the middle cuneiform. This is often done in association with gastrocnemius lengthening. Complications include stretch over time, leading to need for revision surgery. Additionally, if nerve function returns after tendon transfer has been performed, you can get an unbalanced foot with the peroneus brevis acting with no antagonist, and this can lead to a peroneal spastic type flat foot that often requires subtalar fusion to salvage. For this reason, it is recommended that you do not perform tendon transfer if there are any signs of nerve recovery. Additionally, even later nerve recovery can be seen with nerve graft repair, and waiting longer than a year may be indicated in this setting as nerve recovery may happen up to 2 years after. So outcomes on tendon transfer. This is a recent study out of Foot and Ankle International. 19 patients were treated with posterior tibial tendon transfer for foot drop. All patients had an expected decrease in strength and balance in tendon transfer group compared to control groups, but all patients were found to be brace-free at final follow-up. Another study that was more recent, looking at 17 patients with a minimum of 3-year follow-up treated for peroneal nerve palsy with posterior tibial tendon transfer. They found significant improvement in AOFAS scores, FAOS scores, FAAM scores postoperatively. They also found no progressive flat foot deformities, and they found, like previously stated, they only found 33% strength in dorsiflexion compared to the contralateral limb, but they did get 16 out of 17 patients out of brace at follow-up. So although posterior tibial tendon transfer is reliable, it's not without complications, including hindfoot arthrosis and progressive pes planius deformity, as previously mentioned. Therefore, newer techniques have been described to ameliorate these side effects. Nerve transfer, which was originally described in around 2004, has been indicated and has increasing indications for treatment of peroneal nerve palsy. Indications include peroneal nerve transection that is unrepairable, peroneal nerve palsy without improvement on EMG or clinical improvement greater than 5 months from the injury, and patients that are younger than 40. Contraindications include any EMG evidence of reinnervation, older patients with comorbidities, and patients that are greater than a year out from injury. So a little bit about the technique. This was originally described by the group at Mayo, but kind of modified by our group here. They do a single fascicular transfer. The hand team does a double fascicular transfer. Donors usually come from soleus, the medial head of the gastroc, the flexor digitorum longus tendon, or the FHL tendon, based on intraoperative nerve stimulator studies, and they ultimately target the tibialis anterior and the peroneus longus. Outcomes of this have been variable. One of the original articles describing this talked about 11 patients who were retrospectively reviewed with nerve transfer. This was a single fascicular transfer. One patient regained grade 4 out of 5 strength. 3 patients regained grade 3. 1 patient was at grade 2 out of 5, and 2 patients were grade 1. 4 were able to walk without assistive devices at final follow-up, and 4 had no signs of any muscle activity at final follow-up. A recent systematic review of clinical outcomes following nerve transfer for peroneal nerve palsy was recently done. It looked at only 4 studies, including 41 patients with a mean age of 36.1 years. Mean time to surgery was 6.3 months, and mean follow-up was 19.3 months. They found that median dorsiflexion strength in this patient cohort was about 2 out of 5 at final follow-up, and but they didn't find any significant correlation between time to surgery or age of the patient at surgery. So a little bit about outcomes. The OC outcomes have been similar to what's reported in the literature. About 50 to 60% of patients are not using an AFO to return to previous sport without use of AFO. And there's been only one complication, which was a case of fibular osteomyelitis. This is an example of a patient. He's a 36-year-old guy who's now 6 months status post. Nerve transfer with much improvement. He's back to his normal function and is brace free. So in summary, nerve recovery is likely if the patient has an incomplete injury, and observation is the best treatment for these patients. Nerve repair can achieve adequate results if it's tensionless and the zone of injury is small, and if it's performed within 6 months. Nerve grafting has been shown to have good outcomes if the zone of injury is less than 6 centimeters. Nerve transfers have shown some good results in patients, but they need to be strictly indicated, and further research needs to be done on their outcomes. And ultimately, posterior tibial tendon transfer produces the most reliable results in achieving brace-free outcome when compared to a nerve repair or transfer. It can be utilized if these fail, but ultimately you have a less dorsiflexion strength compared to the contralateral side. I'd like to thank these people for their help on this talk. And these are my references.
Great, thanks, Nick. It's a great summary of a bunch of different operative options and a little bit about natural history. You know, one of your indications that you talked about for specifically for the tendon transfers was, you know, people desiring to get out of a brace. My question for you is, looking at a bunch of these, the endpoint was sort of functional outcomes in people. Has there been any study looking at the functional outcomes of bracing versus these surgical procedures, whether it's tendon transfers or nerve transfers? I know the OC study you just showed, you said 2 people were back to their previous sport. But, you know, it's sort of interesting to think about just what is the ultimate function. You know, does it work? Yeah, but is it better functionally than a good brace? Because I know that the brace Dr. Shu helped develop in the military is, I've had patients we've put in it. I know that they are cumbersome and large, and that is probably people's biggest complaint about them, but their function in them is excellent. So do you find anything on that?
Yes, sir. I totally agree. I had that question too. I wasn't able to find anything regarding, you know, tendon transfer compared with AFO use or some kind of modification of an AFO in the literature. But I would be interested to hear, you know, people's thoughts on that, because obviously that's the ultimate goal is, you know, you can do a procedure and maybe they're out of the brace, but maybe they're, you know, wishing they had a brace or hadn't done the surgery. So that's a good question. I didn't find anything on it.
Maybe we can ask Dr. Shu to comment on that. Nick, can you stop sharing your screen so we can go to gallery view and see everybody? And anybody who's on, please turn your mic or your camera on so we can have a little bit sense of community here.
Yes, sir. There we go.
Perfect.
Hey, Josh, it's Glenn. I can jump in if Shu's on quiet mode or on mute right now. But no, I don't disagree. Ours has been kind of average results. Like Nick said, about half of them are out of AFOs. I would say the ones that do well actually do very well. We had one guy that went back and was an all-state football player without an AFO, and I would welcome the sports guys' input. I'm not aware of a single high-level athlete going back to sport after a bridle. I think they can walk without an AFO, but they're not competitively playing sports and running and pushing off and doing everything really hard. At least that's been the experience I've found just in asking other sports guys about it. So when they've worked really well, but a lot of them just don't work. And I really don't know, because we've been pretty selective in doing them in young, healthy people kind of at the right time frame. And even with all that, we're only getting about 50 to 60% good results. So I think that the nice thing about the nerve transfer is you lose nothing. If it's at 5 months and they've got no signs of recovery, you're not going to go do a bridal procedure anyway for another, 8 months to a year. So it's almost like, why not try a nerve transfer? And if you get a 50% chance you get out and you do really well, you've done better than nothing. They're still we've used Joe's AFO as well. So I think having people in the AFO while you're waiting on recovery, I don't think you lose much trying it. It's just that patients need to be informed the results are average.
Yeah, and I will support what you just said in terms of my discussions with Joe previously, is that actually that is one of his complaints, is when they get a tendon transfer procedure early, it can actually compromise their use of the brace and their function in that. So it sort of makes sense.
Hey, this is Todd Irwin again. So a couple comments. One is it seems like, number one, for all these studies that Nick, you showed, I mean, there's a lot of low numbers, right? It's typical orthopedics, but it might lend itself to a multi-center study for stuff that Glenn and the hand people are doing. Two other things. One is, so there's a difference between just a posterior tibial tendon transfer and a bridal procedure. So the bridal is actually, using the tibant and the peroneus longus, and it's a very rigid, good construct, but it is pretty limiting. And so just a straight posterior tibial tendon transfer, especially in a young athletic person, is potentially again, it's just a little bit different. I don't disagree that, like Glenn said, having them go back to high level sports is I don't know of many either that have had that done, but just semantics and understanding the difference between a bridal and just a straight posterior tibial tendon transfer. The only other comment I would have is, I know there's some data out there, Nick, I don't know if you saw anything about this, on early posterior tib tendon transfer in association with either nerve grafting, nerve repair, or nerve transfer. There was some, I think there's a couple articles out there, again, low numbers, but the idea behind it was, if, not waiting a year, if you do it at 6 months, if you're doing a nerve procedure at 6 months, if you do a posterior tib tendon transfer at that time, just a posterior tib, not a full bridle, you are sort of activating your anterior compartment at the same time and keeping it healthy. I think one of the ideas behind waiting a full year is, if the tibant and the anterior compartment are not being stimulated by the nerve that whole time, and they just get atrophy, and then the function is going to be pretty poor. So I think that, at least in some of the communities I've been in and people I've talked to, that was a bit of a push. I don't know if it's really caught ground at all, but there was, it was sort of a thing trying to tell the sports guys, hey, get these, and Glenn, it was Paul Soderna who was the one who kind of really, pushed it on me and say, hey, get the sports guys to get them in us really soon. Don't wait a full year before the nerve is gone. Let's combine a nerve procedure with a posterior tib tendon transfer early. And Nick, your complications from that, I really haven't seen that. The whole hindfoot arthrosis and peroneal spastic flat foot, just again from an isolated posterior tib tendon transfer. I really haven't seen that. I'm not sure if my colleagues have, but I think that's something we need to think about, because I think that could be an improvement in the protocol for these knee dislocations and peroneal nerve trauma.
Definitely, yeah.
Hey, Nick, it's Brian Brighton. question just for the in your literature search in terms of causes and etiology. Did you see deformity corrections for the valgus, knee, whether acute correction or total knee, or even really rotational osteotomies of the tibia having sort of a incidence of peroneal nerve dysfunction and management of that sort of?
Yes, sir. Yeah, definitely in total knee arthroplasty, with severe valgus and then flexion contractures, I think it was, as high as 4% of those patients end up with peroneal nerve issues. Soft tissue releases can, help mitigate that a little bit, but it was tough to, find literature on outcomes of those just because patients are older and have a lot more going on than just, a multi-ligament knee injury in a young patient. But it seems like it's fairly common and something to watch out for in those patients with valgus and flexion contraction. I didn't see anything about deformity correction, like what you would do.
Yeah, we will typically, if they're doing a valgus correction, not so much the distal femur, but if you're either doing combined distal femur and a proximal tibia, a lot of times we'll do the tibia gradually, but you have to think about, doing a peroneal nerve decompression, at the time of your, lengthening or deformity correction there to prevent that. So doing a sort of a preoperative neurolysis there.
Yes, sir. That makes sense.
Great. Well, Nick, thank you very much for a great talk. Thanks for everybody for tuning in and interacting. And we will look forward to catching up with everybody next Thursday morning. Thanks again, and we'll see everybody. Have a good holiday weekend.